So thank you. First of all, I'd like to thank NHBC for the opportunity to provide an overview of the innovative cross-study industry tour that we're going to talk about today, that was aimed to learn from industry leaders around optimising the delivery of virtual care and application of digital tools to improve health outcomes and improve the experience in care and operational sustainability of care. I'm going to go straight to this slide. So, as you can see, there's a number of logos on the screen, and I'm going to talk today about how this all came together. So this cross-industry study tour and piece of work that we did investigated international models of integrated care enabled by virtual and digital healthcare technologies. The purpose was to identify how health consumers and the health industry can scale the virtual care to benefit patients and communities in more settings. Our approach to this study, which was led by Carla Edwards from GSA Raleigh, and Carla couldn't be here today, so I'm speaking on her behalf, was to bring together representative and organisations from across Australia and New Zealand that are proponents of the opportunities for virtual and digital healthcare. We knew that success would come from a whole-of-system approach that broke down the silos between different disciplines and specialists and industry players in the health sector. The collaboration group included architects, healthcare advisory, health planners, health economists, health consumers. It also involved people from New South Wales Health Infrastructure and Government of New South Wales. Bringing together such a broad and deep group of disciplines and expertise helped us analyse the challenges from a multifaceted perspectives, and it was really important to spark new ideas. Everyone came at it from a different way, which was fantastic. Together we studied and learned from some of the industry's best. Overall, we had a lot of fun and some amazing experiences, and we're going to take you through a few of those in our slides today. So why? Why did we undertake this study? So our burning platform. The study group believed that virtual healthcare can address the burning platform that we've outlined up here around capacity crisis, addressing equitable access to healthcare, and delivering more personalised healthcare. The study explored sites to understand how virtual healthcare models described were addressing moving care from the hospital to the home and the community, and how virtual healthcare may address equity of access for our most vulnerable populations. We knew that technology, digital systems and AI were essential to unlock productivity and transform care. As you can see, we've got a number of mega trends there listed on the slide, and they're important for our study to understand how each one of those was working. So prior to embarking on this rigorous study, we started with a desktop review and a gap analysis of virtual healthcare strategies and a review of national and international virtual and digital healthcare strategies and models of care. The goal was to identify existing knowledge and experience in Australia and New Zealand healthcare and compare to international approaches. This rapid scoping study that we undertook uncovered potential gaps, which served as the foundation for the study's focus areas. There was 4 focus areas. First one was models of care. What do we mean by model of care? As we know, everyone has a different meaning to what model of care is, and when we started looking at international models, it became apparent that we were talking about very different things. So that was our first question. What is the model of care? Change and adoption. We read some amazing studies from overseas before we went over that had implemented virtual models. Seemingly, they had managed to do these amazing programs without a massive struggle. So we needed to understand how that actually happened. We needed to understand what was required from a digital tools and technologies perspective. And then for infrastructure and design, what we needed to support these models. So next we developed and refined the study questions. These questions aim to gain a deep understanding of each of the focus areas. And then we visited 24 programs over 6 countries, either through some virtual site visits, which were Canada and the US, or on-site visits to Denmark, Sweden, France and England. Why did we choose these sites? Scandinavia was chosen because it was seen as the pioneers in care in the home. England, because it was always known as an early leader, we needed to see what was going on there. France was seen as an emerging leader in bringing innovation and technology to deliver new care approaches. Canada, the challenges with distance and remoteness, plus addressing First Nations and displaced populations. And the US, once again, was another early leader. So there was where we went from a virtual and also a physical perspective. So from our observation,
we developed 5 key themes, and these were the 5 principles that we put together for the study. The first one being innovation starts with just starting, and that was something that we saw, especially in the Scandinavian countries, which actually look at innovation and virtual care. We talk about from the bench to bedside, but their process is a national process. There's no competition between universities, there's no competition between states. So the implementation and the random testing of any programs is achieved in quite a significant reduction in time. The other aspect that we saw was participatory design. Now, whether that's consumer-centred or staff-centred, that was really important to test the programs as to whether they have a viability with staff and with the patients. The next step was moving to data-informed, personalised, hybrid models of care. And one of the things that we did find is virtual care is very data-intensive. A lot of the time we thought that it didn't require a great deal of data, but in a lot of the sectors, particularly in Bridden, and recently I was in Singapore and Tan Tock Seng Hospital, and they've integrated their full virtual care and AI into the command centre. That was a real issue, and also the issue that we found, particularly here in Australia and sometimes in places like Canada, was the access to the internet and maintaining the bandwidth that is suitable to engage with the patients and for the staff in the either primary care or acute care hospitals. One of the overarching items was iron prevention. The whole aspect of a lot of the virtual care programs was the prevention of acute care or non-communicable diseases. So that was really important in all the jurisdictions. And the final one was just the health workforce of the future. And one of the interesting things that we did find was that the staff are really keen to embrace virtual care. And in a lot of the facilities, it was just realising that a patient, whether they're in the facility or at home, can be scheduled in terms of their daily schedule. So the innovation starts with just starting, as I mentioned, end-to-end process, and it also requires a significant amount of governance on behalf of government, NGOs, and also the tertiary institutions, so that that can be achieved across the spectrum of virtual care. So we found that in a lot of the jurisdictions, there were big ideas that started small. They started with a small cohort of patients, and then they moved through to develop the programs. And the other aspect with Kaiser Permanente, and that's a large HMO in the States, and non for profit, and certainly not for loss. But CEO, sorry. But they, across their 10 wounded hospitals, they've embraced virtual care, looking at the way that the staff work, making sure that within the acute care setting that they have the ability to treat a patient at home or in another primary care clinic. So that was quite important. The other aspect that we saw was participatory design. And there was one study that we saw in Denmark called the Acura, where it was looking at pre and post rehabilitation for cardiac and orthopaedic patients. And that was a real success. It's been rolled out right across the 32 local health districts, and it relies on the use of wearables. And we actually spoke to some of the patients, and they were really keen to be a part of their health continuum. And the interesting thing, it also reduced the amount of time that they had to utilise allied health facilities in the hospital. So they were using it for other alternate community uses as well.
Okay. And then we also have blended care models and design preterm care. And so we went to a hospital in Sweden, and it was a NICU virtual care model. They supported premature babies to go home early from the NICU, and it started from the day that baby was admitted into the clinical care. The virtual care program was integrated within the unit in clinical care, and they started having conversations at that very admission point, that the next part of your care, after we get your baby to a point of near-end discharges, that you'll go home in virtual care. So one day the nurses would work in the virtual care, seeing patients virtually, seeing their babies, seeing their mothers, or next day they could be working clinically on the floor. So it was very seamless, and there was that continuity of care. With this, they made sure that the parents had instructional videos on how to use virtual care, where to make sure that the baby was in good lighting. They sent them to an iPad and a stand. And they really were involved in making sure this was a success. So they managed to lower the length of stay and get their babies home a lot quicker, which had worked to a decrease in the amount of infrastructure spaces they needed in their redevelopments. This is rolled out across the country.
Yeah, so as I mentioned, moving to data-informed, personalised models of care, and as we mentioned, the use of AI and also a networked provision across the healthcare continuum is becoming really important. And some of the case studies that we did see were both in Bridden and recently the one that's been just opened in Singapore, 10 times seen, utilises AI from all its patients ringing either for an emergency call or a general call, and if it's required as an urgent call, it's uplifted to a person. But it's quite an amazing system, and they've been trialling it for a number of years now, but they utilised 10 to 15 years worth of data. So it's taking them about 10 years to get to that point.
We're running out of time, so we're going to move through just to the slides where we talk about our findings. So for an eye on prevention in wellness. So what we observed was that it was a whole of person care, integrating health, visual health and wellbeing through all of the digital tools. That was very apparent in what we saw in some of these programs in that they had many different kinds of clinicians involved in developing up the virtual model and making sure that it's a success across all of those parameters. Moving from sick care to health care and application of digital for early detection as well.
Yeah, so I think the other part of this was in most of these jurisdictions, they're spending a lot of time training the staff. Now, whether they're using gaming protocols, they're utilising a whole lot of training in the situations that may occur. But it's a real part of the protocols, and they're introducing it to pre-grad and post-grad students in the universities in Denmark, which was quite interesting.
So, acknowledgements. We deeply appreciate you saying all of the national and international health and digital leaders and nations, innovators, researchers, and participants in our cross-industry collaboration who generously shared their time for this study. There is a light paper that has all of the different virtual care programs in much more detail than we've gone through today that can be accessed from there.